So Chris, tell us a bit about, you were there from the start. How did the pain service come about?
Yeah, the pain service came about in about 2004, and it was because the local pain service, the hospital trust, again they were kind of overwhelmed with people needing to be referred in, and they were struggling, I suppose, was the reality, and the CCG, the Clinical Commissioning Group, they got involved, and they said, well, we're happy to support a pain service, but we want to look at doing things slightly differently, because the evidence base was starting to change around that time from interventions in pain to more of a kind of a sustainable way of managing pain, perhaps people would say non-interventional way of managing pain. It was becoming apparent that there are other ways of managing pain, and so I think the CCG wanted us to start exploring that. And I'd already been involved in setting up a pain service in Liverpool a year or two earlier, so I got involved then, and so we planned it, and we implemented it. It was really small at the start. It was me and a physiotherapist, and just offering 1 or 2 clinics a week. And I think at that time we probably had about I don't know, 5 or 6 people referred in a week, and it just grew really. And so yeah, that was kind of the start of it. And I think we collaborated a bit with the Acute Trust, who run the pain service there. And again, it was kind of obvious that we'd wanted to do things differently. I mean, my pain training was specifically originally it was quite interventional, but I'd done a pain fellowship, which was for a year, and that really was focused. I was able to define my own kind of pain training at that time, and so with the mentor and with the Walton Centre who was doing it with, they said, fine, you do what you want to do. And so I focused a lot more on community stuff, and so it wasn't so much intervention, but a lot more about rehabilitation and diagnostics, and so it started that way really. And the physio that we had, she was keen, and she wanted to kind of be involved in helping people rehabilitate. So
and why develop into the multidisciplinary team we have now? Why do that with pain?
I think it was apparent that we know pain is such a multifactorial thing, and we recognised at the time it was kind of a foot in the door really of getting pain services started. We knew the physio and medical support in the service was important, but we needed other disciplines as well, and psychology was dead important, and occupational therapy, and there's lots of different elements to a pain service. But yeah, we started to look at putting a business case together for how we would develop into a multi-professional team, and that came about probably in about 2007. We were doing the business case, and then 2008 we got it kind of agreed, and I think that was about the time that you came on.
I started about 2008, I think.
Yeah. And what were your thoughts when you were kind of getting involved in a pain service that was like kind of so small and like, not really, like kind of non-existent really?
Well, I was up for a challenge really. I was used to working with people with long-term health conditions, but at that point wasn't particularly specialised in working with people with long-term pain. And I remember when I was kind of first starting and meeting with you, and you said, so Becky, what do you know about pain? And I said, not loads actually, but I know quite a lot about working and having conversations with people whose lives have changed as a result of a health condition coming along.
Did I say I didn't know loads about pain?
I can't remember actually. You were in your GP practice at the time, I think.
Yeah.
And then I think we were talking about, what difference psychology might make, and why did you want psychology as part of the clinic? And I'm curious actually as to what you think about that. What difference has psychology made? I don't know.
Yeah, it's it's really interesting to reflect on that, because I think of my journey in pain, and obviously with my background originally in anaesthetics and kind of an anaesthetic focus to pain, which largely I think is as an anaesthetist you're kind of quite procedure based. It's a practical specialty, but then going into general practice, you kind of see another side of communication and kind of long-term management of things. And the pain fellowship that I did, it was, as I said before, it was kind of much more focused on diagnostics and rehabilitation. But again, in the environment, it was kind of a year-long fellowship that the anaesthetists do. And again, it's quite interventionally focused. And I think I started off this clinic with a view that we can build perhaps interventions into rehabilitation a lot more than we ended up doing, really. And I think when we started working together, it was like a bit of a light bulb moment for me. It kind of made me realise there's a load more to it than focusing your medical input into interventions. And it kind of made me realise the power of really learning and aspiring to good communication skills and how you can bring up the best in people. It stopped being about what I can do for people, and it much more became an emphasis on helping people uncover what they do day to day for themselves and the skills that they have, because that's going to help them at 3 a.m. when things are really bad. I'm not going to help at 3 o'clock in the morning when things are really bad. And the resilience that people have and their own toolbox is, a vital ingredient. And so it really opened my eyes to that, I think, and the power of how we communicate. I think I thought as a GP that, you get good training in communication, but kind of you realise there's more levels to it than that. And that really helped me, I think, having you. And I continue to learn in that way.
And for me, it helps being embedded as a psychologist in a physical health team, because I absorb and learn aspects of kind of pain physiology from you guys, from physios, etc. And that helps me in my practice when people are looking for better understandings of pain. I work with colleagues and I can also reinforce those messages sometimes. So being embedded in a team, I think, is really helpful.
It's funny, isn't it? Because we talk about the biopsychosocial, we use this term biopsychosocial, don't we? And I think it reflects many levels, doesn't it? Because you've just hit upon, how we operate biopsychosocially as a team, and we bounce ideas off each other. And when we have our MDTs, it's not like I would refer somebody to you necessarily because you do the psychology bit. It's like we all kind of have an understanding of our of each other's skills, and so that rubs off on us really. And so we hopefully aspire to operate biopsychosocially as clinicians, and how we consult with people as well.
And I think we aim to look at the whole person. So biopsychosocial are all factors in that, but within that we look at the whole person and what they want and what's important to them, and that's definitely infiltrated in your practice, as I've noticed over the years.
I think it has. The different, I suppose the different ways that you ask things. That's been a big shift for me, is trying to ask things in a curious way and genuinely having a curiosity about what works for people. And I think also a meeting of expertise in a consultation, because I think, in medical school, and I suppose in a lot of other, clinical specialties, you kind of, there's a lot of pressure on you to be the person who's got the answers. And a great lesson for me, which, as I say, I continue to learn is you don't always have all the answers. And, often people have better answers than you. And it's being open and receptive to that, and not feeling like you have to, solve everything. And, you can you have an expertise in something, but people coming into that consultation, they have an expertise as well. And the greatest things happen when the two of those meet. I think that's been a real powerful thing for me that I've learned from you.
So you've grown your curiosity in looking at what talents people already have and what they want more of, and that makes a difference in the practice of pain management, of living well with pain.
It stops being a transactional, I have this pain, somebody coming in, I have this pain, and then the clinician or doctor saying, well, okay, I can do this for that. Because, automatically then, because we know how, how multifactorial pain is and how unpredictable it is, those treatments might work. And so you're you're setting up, kind of disappointments all the time, really. And I think having something, a management planning context where it's an agreed management plan and we're using all the skills that people have, there's different strands to their management plan. So if that doesn't necessarily work, or we've got a few other things that are on the go as well. And, so it's 2% from that, 4% from that, and maybe they get a good benefit from something else, medicines or interventions, but we're not holding all our hopes out on that. And, it's much more about, utilising everything you can, I think, and helping people, kind of understand, I suppose, that, interventions have a role to play, or medicines may have a role to play, but it's not the only role.
What would you say is the kind of focus or the ethos or the purpose, if you like, of the service now? So if someone walked through the door, what is the kind of aim, I guess, of the service?
I think for me, it's always about people being understood and being listened to. And if we fully listen to people, then it helps our understanding. And when we understand people, then we collaborate better and we get a better result. And I think the key to that is in there's loads of keys, and I suppose it starts with how we greet people, and how we the first couple of seconds in a meeting that we have with people. But for me it's all about listening and being responsive. It's, of course, I guess my default as a doctor always is I've got this kind of spinal reflex of diagnosis and what can I do, what pill can I give? I kind of have to suppress that a little bit sometimes, but we have to make sure the things fit together. And I think my role, I guess, as a doctor in the service is making sure diagnostically it seems right, and that there isn't risk associated with diagnoses that perhaps haven't been uncovered. But the best will in the world, I think, people who've seen other clinicians, pain's a complicated thing, isn't it? And sometimes diagnoses are missed. Not often, but we just got to be aware of that. Really, we have to have a foundation in. There's a medical. That's why it's a biopsychosocial. There is a biological bit to it. We have to be mindful of that. But it can't rule everything. That's the thing for me.
So people can expect a good listening to and understanding, and of course, the usual, if you like, medical stuff of diagnosis and treatments where possible, but also framed in this context of what this person wants, and using the skills of the team to help them get there, and use what their own resources to help themselves get there as well.
Yeah, definitely. Definitely. It's that collaboration, I think, isn't it? And from the psychology side of things, Becky, how do you feel, people respond to you when you, when you see people in a pain service? How do they normally respond to kind of...
I think everybody's different. I think it depends on what they've kind of heard already about, what do psychologists do. I think I'm really careful about helping people have the message that seeing a psychologist doesn't mean the pain's all in your head, because that can be a misconception sometimes, which can be really hurtful. Why do I need to see a psychologist? So I think, everybody's different, and everybody wants something different from coming to see a psychologist, which is basically about having conversations about trying to live as well as possible despite pain being around in people's lives. That's how I tend to kind of frame it, and then we take it from there.
I think the thing, I've just choked on my coffee, that's not excuse me. I think the thing about pain being in your head is a really, really important thing. It's something I encounter a lot, because people have heard different explanations of pain, and it's very easy to misinterpret. I think when somebody talks about pain and the way pain is modulated and the way pain's constructed, I think it's so easy to get into that pitfall of people walking away thinking that you're saying that this is in your head. And at the end of the day, it's in your brain, isn't it? But it's a different connotation by someone understanding it's in your head.
And perhaps we can talk more about that.